Hello, everybody. My name is Dr. Vince Gutierrez. I'm a physical therapist. You can find me at movementthinker.org. You can find me on Twitter at NVivoPT. Physical therapy, in the DPT Mentors page, I try to stay active on social media platforms. So, anyway, these are some of the presentations that I'm working with physicians. So I have fairly close ties with some physicians groups. And they're asking what are some of the non-conventional reasons why we should send a patient to physical therapy, because they know post-surgical. They don't necessarily know pre-surgical. But these are some of the topics that I've been bringing up with them previously, such as the knee pain, non-traumatic knee pain that you saw in the last lecture. And so here's another article talking about physical performance as a predictor for depression, and is there a predictable relationship? So this was an introduction in that, and again, this is just a summary of that article. But the prevalence of depression, it's up to 10%-ish in community dwellers. And there's been an unclear relationship between physical performance and depression. I believe there was only one previously published study that spoke to physical performance and depression as there being that correlation. And when we look at physical performance, it's everything listed there. You can read those. Older adults' self-reported physical function is inconsistent and weakly associated with their actual physical performance when measured objectively. I thought this was extremely important for us to note, because we use subjective outcome measures for our patients, and there's my insert opinion here. We use subjective outcome measures for our patients, and insurance companies really like for us to use subjective outcome measures for our patients, even though those subjective outcome measures may not actually catch the problems that the patients are having that we would see objectively. And don't mind the kids in the background. I've got plenty of them. If you want a basketball team, I could probably field it. Some of the objective measures that we would look for are gait speed, power production, and measurements of strength by way of a dynamometer. But again, ideally we're doing some sort of objective measurement when we're working with patients that we can actually get numbers for, that we've used a stopwatch or something, a scale, some sort of objective measurement. So the introduction for the study, like I said, don't mind the kids, they talk all day. The introduction, aim of the study was examine which physical performance measures provide an optimal prediction of incidence for depression in a representative cohort of old. All right. So again, this was a study that was done based off of data that had already been in the system, and they followed patients over the course of 4 years. It's 4.4 years on average. And they had baselines on these patients, and then they looked at these patients 4.4 years later, and they started putting relationships to numbers. The hypothesis would be that, the worst physical performance would correlate with a higher depression risk. So the source, this was about 3,100 patients, and this is from a study in Italy. The follow-up, like I said, was 4.4 years after baseline. The methods, they did a face-to-face interview. Physical activity was defined as greater than 4 hours per week in the previous month. That was the median value of the sample. They actually, the participants did greater than 4 hours per week on average. For functional status, they used the ADL score, and for cognitive status, they used the mini-mental. Physical performance and muscle strength was assessed using objective testing, such as the short physical performance battery. So you had the 4-meter walk test, the 5-time sit-to-stand test, and then the feet together versus semi-tandem versus full tandem, and then it was scored accordingly. The sit-to-stand test and the 4-meter walk test were also used as separate variables because the authors believe that those two tests may actually pull out ratios, or the odds ratio for developing depression over time. So they looked at knee extensor and hip flexor strength using dynamometry. They did hand grip strength testing, again dynamometry, and the 6-minute walk test. Again, don't mind the kids in the background. They're just not watching something that they enjoy. The depression. And so the baseline and follow-up was done using the geriatric depression scale. There's a link to the form there if you're interested. And the cutoff for depressive symptoms was more than 10 points. I believe it's a 15-point scale. It's already been days since I've looked at it, but I believe it was a 15-point scale. So if you look at how this worked out, they had about 3,100 eligible. 990 were excluded for missing information on one or more tests. 794 were excluded because they already had depression. And this is interesting because they go back and they play with that 794 towards the end of the study. You get to read about that. 153 dropped out. They didn't have information at the follow-up. 192 died. That sucks for them. And then there were 970 remaining for the final sample. So the dropouts and the people that died had significantly higher the GDS scores at baseline. And those that had depression and died had worse scores on all physical performance tests and strength tests. People with depression at baseline also had worse physical performance testing. And so when I read that, right, and I'm hearing this, these are one of the first conversations that I'm having with the physicians that are referring to me is, can we improve these physical performance tests? And I don't know if the research is out there because, again, this is the first research study that looks at all of these variables, but can we improve their physical performance? And will that improve their depressive scores? And the authors go into it in the discussion as to why they think they may have depressive scores when their function declines. Increased depressive scores when their function declines. And we'll cover that here in a couple of minutes. So 207 were diagnosed with depression at follow-up. They were significantly older. They had worse cognitive status based off the mini-mental, higher GDS scores. There was no correlation between those with and without depression at follow-up for the following: smoking, education, monthly income, self-reported physical activity, BMI, ADL scores, comorbidities. Right now, I would have thought that monthly income may have played a role, right? I would have thought that self-reported physical activity would have played a role, but that was before I learned in this article that self-reported measures may not actually reflect what's happening in the patient's life. When we look at odds ratios, so they looked again at the physical performance testing, and then what are the odds that person ends up developing depression, right? And so those who scored poorly on the short physical performance battery were 2.71 times more likely to develop depression. And then again, you see how the numbers play out. The 4 meter gait speed, 1.79 times more likely. 5 times sit to stand test, 2.05 times more likely. Hand grip test. This is actually a really quick one to test. So almost 2 times as likely to develop 1.75. Sorry, keep your numbers straight, pal. 1.7 times more likely to develop depression. And so compared to those that didn't develop depression, right? And so we're looking at how these scores play a role. And so they had increased risk of developing depression if they scored poorly on these testings. Poor performance at baseline and depression was significant for women for all of the tests. So if for women versus men, a poor performance on any of the tests was a correlation of the woman developing depression over the course of time. But for men, only the 4 meter gait speed test and the short physical performance battery correlated with depression over the course of the 4.4 years, which indicates that maybe this SPPB should be something that we're testing in the clinic. These are the discussions that I'm having with some of the physicians now. Reduced physical performance was significantly associated with depression over a follow-up of 4.4 years in older adults. The SPPB was the most optimal measure to test the correlation. The authors hypothesized that the impairment of the test may lead to impaired function and therefore isolation. There is some research out there to talk about how isolation is correlated to depression. And the authors suggested to use the SPPB and the hand grip test as routine screening. And I think the hand grip test, I mean, aside from the cost of the dynamometer, the hand grip test is relatively quick and easy to use. And so these are one of the things that I'm discussing with the physicians, that maybe they can do that as part of their routine screening. And for patients that are depressed and are older, maybe send them to physical therapy for just an examination to determine what their walking speed is, what is their power output, what is their balance, and is there a way for us to improve upon that if they need it after the evaluation. So again, just highlighting this, poor performance on physical performance testing is an independent predictor of depression, and the short physical performance battery test appears to be the best test performed for the screening based off of the odds ratio. Remember, the patient who scored poorly was 2.71 times more likely to develop depression. So for me, I take from this the clinical implications for this is that this is additional research that supports the recommendation of screening for patients. You know, we're hearing more about that yearly physical therapy appointment. And I think we need to embrace that as a profession, where the patients come in not necessarily for treatment, but they come in for screening to determine where are their limitations, and based off of the limitations that we see, can we help the physicians plan medical management over the course of time? And this is where we have to come together and communicate as the medical team for for what's best for the patient. And this could be utilized to educate patients on the benefits of a yearly evaluation by a physical therapist, right? So if we already know that patients that score poorly on this are, over 2 times more likely to develop depression, can we nip that in the bud before it happens, right? So can we keep their performance from starting to lag behind their peers? And so we can at least give additional data to the family physician that the patient can be flagged for additional screening either at the time of the evaluation or at a later time. Older patients with depression may benefit from screening to determine physical performance and possible improvement in regards to their changes with socialization. And so if we can keep patients on their feet, if we can keep them walking at a relatively fast pace, these patients are more likely to continue to go out into the community, and that community socialization may help to reduce their risk of depression over the course of time. That's what the authors hypothesized, and and I see it. I hear it from some of my patients in practice anecdotally. They want to get out of the house. They need to get to the store. Just going to the store is a big deal for some of these patients. This is a link to the short physical performance battery. Here's the reference from the article that I took this information from. Feel free to read the article. It's actually a really good article. Feel free to read the article. Comment below if you have any questions, comments, or concerns. If you have any ideas for how we can use data like this to better improve our profession, but also to better improve the communication that we have with other professionals, I welcome that. Comment below. Thanks for watching.